We are very fortunate to have Deborah Kornavaca with us today. She has, as you can imagine, an incredibly demanding schedule as Deputy Chief of Staff, and she's found a way to be with us this morning. So I'm going to welcome Deborah. She does come to this work with a background that really allows her to have a deep understanding of many of the issues that you are going through. She has a background in academia, comes from a family of educators as well, and has a great sensitivity to the work that you all are doing. And I have to say, she's been a wonderful partner in working with us at the New Jersey Principals and Supervisors Association and making sure that the governor's office is fully aware of your concerns, your needs, your issues, and has been a great advocate for those in the education community. So Deborah, thank you so much for being with us.
It's my pleasure. I hope I'm not on mute. Somebody can give me a thumbs up.
We can hear you, absolutely.
Right. Excellent, and see my screen as well, I hope.
Yes, that's right.
Thank you so much, David. Thank you for the invitation. I'm always thrilled to come spend time with people involved in education. It's a core passion and part of probably my DNA. So thank you for having me. I hope I could stay to listen to some of your other esteemed guests because I'm sure I could pick up some knowledge and tips along the way. What I was hoping to do for your meeting this morning was to walk through a little bit of the approach that the state has taken with respect to our vaccine program, to give you a little bit of an understanding of why we're at where we're at and what the eligibility is and how we're able to move forward together. I'll run through this, I hope, fairly expeditiously so that there's some time for Q&A. I do want to say that we're not sharing this PowerPoint because we update the numbers and material in here on a weekly basis. And so I'm a little bit nervous about having slides out there in the long run that could be outdated to be shared. I know this is being recorded, and as long as we think the material that I'm presenting today remains current, we will certainly keep this recording live for you all to share. Quickly, we want to understand how we got where we're at, what the decisions are we've made to get here, and then really the nuts and bolts, because I know there are a lot of questions about eligibility, registration, who, what, where, when, why, and how, as we say in the classroom. The general strategy is based upon some background information that's important to have. The first is, I think you know that it was on December 11th that the EUA, the emergency use approval, was given to Pfizer for the use of their vaccine, and Moderna got theirs a week later. At the same time that all of their trials were going on, the CDC had the Advisory Committee on Immunization Practices, which is known as ACIP, developing their recommendations for states. And like most things and it brings me some joy, I apologize for anybody, but I'm going to say it, brings me great joy to say, under the previous administration, their approach was very decentralized to give us kind of vague recommendations and then tell states to go figure it out. Now, there's pros and cons to that approach, but basically what ACIP gave us was a very general framework within which they said, you at the state now go figure it out. So the state developed its initial vaccine plan as the federal government required it back in October. And as you can imagine, that's very much the cart before the horse. They said you have to submit a plan in October when we didn't know what vaccines might come on market, when they might come on market, how many would. But we put together the best plan we could. And then we had our professional advisory committee, known as the PAC, review federal recommendations to develop the New Jersey specific plan. So within 4 days of the vaccine being approved, we had our first set of doses in New Jersey. We began the Pfizer vaccine on the 15th, and a week later, we began doing the Moderna vaccination program, both of which are ongoing. The goals of our program, as stated in the executive summary you can see online at the Department of Health vaccine plan submitted to the federal government, is to provide equitable access to all who live, work, and/or are educated in New Jersey. Other pieces of this are important, but I want to focus on this because equity really is the lens through which we're seeing all of this work. And it's also important to emphasize that if you live, work, and/or are educated in this state, you are eligible for a vaccine in this state. We know a lot of testing work was very municipal, county-based. You had to show you lived in the county or the municipality to access testing. This is not true for vaccines. The only exception is county-run sites have been given the ability to give priority access to their county residents or people who work in their county. That's a little complicated. We're still working out some of the kinks in that, but they were very adamant about wanting to serve their county first. And so in exchange for them helping vaccinate people, we've worked out some compromise. But if you live, work, or access or are educated in New Jersey, you can find a place to get vaccinated here. Our goal stated up front, and again, this was way before we actually had a vaccine in hand, was to get to 70% of the eligible adult population within 6 months. We're concerned about meeting that goal because of the supply chain, but we'll talk about that in a minute. Two general approaches we can take to a vaccination program. There's lots of space in between, but I'm giving the extremes. One is a very centrally controlled, few places to get vaccines, few places to register, maybe just one system program, where maybe we would have 3 mega sites around the state would control all registration. You have to go to one of those 3 sites, akin to what we did with testing in the FEMA sites when testing was very scarce and we could set up just a few sites. The other one is a less controlled, more decentralized, where we're putting more testing sites, more vaccine sites into the communities. But in doing so, different places have their own ways of approaching delivering healthcare to communities. And so you lose a little bit of control, but you get a deeper penetration into communities across New Jersey. Both have advantages and disadvantages, but with the view of equity, the lens of equity, it became very clear to us that we needed to use a more decentralized approach, that using just a few hub vaccine sites, while it would be cleaner and neater from the front end, would not allow for the equity that we want to achieve, because you'd be forcing people who may or may not have transportation, may or may not have the extra hours to make that trip to certain vaccine sites to get vaccinated. And the way that we're going to achieve a more equitable distribution is to bring the vaccines to communities. So we felt strongly the need to do that. We began immediately, obviously, with our hospitals across the state. And we acknowledge that in this decentralized approach, there is less control. So there's more inconsistencies people may find or confusion. We'll help sort through that with people as it comes up. And we're also helping clean that up as we move forward. But the other important piece of the decentralized approach is it will allow us to build a system to scale as we get more vaccines. Because obviously, if we right now don't have very many vaccines, we're not going to see very long lines at our mega sites. But if we get what we want to be, which is, multiple fold, exponentially more vaccines, we want to be able to have multiple sites be able to give it, so you don't have to wait in line. You don't have to wait to get an appointment. You can go down the street or in your neighborhood, get a vaccine in and out like you would a regular doctor's visit. So we knew that this was also the scalable approach to doing it. It can make it a little bit more complicated at first, and we acknowledge that, but we think that it's the necessary approach both for equity and growth. Where we're at with vaccine quantities is we were told we would get slightly over 400,000 in December, knowing that started in mid-December. We actually got about 20% less than that, about 390, I think, or 384. It was, 20% less when you're talking these numbers is 20,000 people who couldn't get vaccinated. To us, that's substantial. We did set aside of those vaccines, 120,000 for the long-term care facilities. Those are being vaccinated through a federal contract with CVS and Walgreens. They're making appointments with long-term care centers and other congregate living places and vaccinating both staff and residents there. So in January, this was as of last week. This week, we've got about another 100,000. We're getting about 100,000 a week. And we've been told that that's what we should expect probably for the next month. Our second doses, you should know, are kept separately. So when we talk about our weekly allocations, we're talking about first dose allocations. The second doses are not counted in that because they're immediately set aside when the first dose goes out into the state. Host of considerations that we'll come back to a little bit. We want to make sure that as we're figuring out the logistics of this, we're also doing education and building trust. And we know in particular there are communities where historically access to medical care is harder to get and trust in vaccines is very difficult. Specifically within our Black communities, we know we need to have an education program that is robust, that is accessible repeatedly over time in local places with validated voices of people who are trusted in those communities. And we're working very hard to stand those up even before there's access to the vaccine so that the education and answering questions is going on. We also frankly know that where we are not putting forth an affirmative message, building trust, answering questions, what fills the space is misinformation. And then it's twice as hard to combat misinformation as it is to initially get out there in front of it. So these are really strong, programs that we're standing up as fast as we can. I will also just say we're very hopeful now. The Biden administration will be announcing some of their COVID programs today. And, one of the key things that we're looking at is the funding for the vaccine program. It's our understanding that they will be ordering FEMA to begin reimbursing some of our expenses because the federal government was offering very little in terms of support, and which means that this is very costly and it's harder to stand up vaccine sites where there isn't already a medical infrastructure that can handle it. And even for those medical infrastructures, there are costs. So some of the nuts and bolts. It's very important to understand that most of what you see in the press is reflective of the ACIP, the federal general recommendations, which does not reflect what each state is doing. And if you look across the landscape, Massachusetts, Connecticut, Rhode Island, Texas, Illinois, California, we're all doing different things because these recommendations came to us in a general form. But when you see a lot of the newspaper articles and they refer to priorities, they're really referring to the ACIP priorities put out by the federal government. And you have to dig deeper to understand what our state is doing. But generally speaking, there were two buckets that ACIP looked at. One was the prevention of morbidity and mortality, and the other one was preservation of societal functions. In morbidity and mortality, it's the people who are older in congregate living settings and people with high-risk medical conditions, those who are most likely to end up hospitalized, needing intensive care, using resources in hospitals, and sadly, much more likely to pass away as a result of COVID as a general, rather than a general, healthy person with no comorbidities. The societal functions one was really about our essential workforces, and that's where educators came in. In each bucket, there's a 1A, a 1B, and a 1C from ACIP. So 1A in mortality and morbidity was long-term care, congregate living centers. 1A in societal functions was our healthcare workers. And I think everybody had a fairly agreeable understanding about why these were our 1As. 1Bs became somewhat more complicated, and we'll come to that in just a minute, as well as the change that the federal government gave to us, I think it was last week, but time kind of blends into each other. So who is eligible right now is all healthcare workers, doctors, nurses, pharmacists, essential caregivers. It's a very broad definition of healthcare workers. It includes essential caregivers who may or may not have a job doing it, so they may not have an ID proving it. Volunteers are included in this. Community healthcare workers, trainees, and students are all included in this. Long-term care and congregate. And then we started 1B with sworn law enforcement and fire professionals. Now, in addition to that, as of January 12th, the CDC issued new recommendations that the state should open eligibility for everybody who is 65 and older and those who are 16 to 65 in the CDC high-risk categories. The definition of high-risk categories is listed here. We have also broadened that a little bit more. CDC has high-risk categories and possible risk categories, and we've expanded it to include at least some of the possible risk categories. For example, you'll see on our registration site, we list both type 1 and type 2 diabetes because we have not seen, there may be, but we haven't seen it, the scientific evidence to say that type 1 and type 2 diabetes patients react differently to COVID. So if type 2 is a high risk, we are also pushing in type 1. So again, that's a place where ACIP gives us recommendations, we adjust accordingly. What this did was it said, if you go back here for a second, was it said that the prevention of morbidity and mortality, 1A through 1C, now becomes the priority over the other bucket. The way we had originally understood recommendations from the federal government was that they were kind of going to be balanced. We were going to move through 1As in each bucket, 1Bs in each bucket. But when they made this decision on the 12th, they said your morbidity and mortality bucket takes priority over the other one. And the reason for that is probably fairly simple to understand. If you look at what's happening across the nation, if you look at California, they're suffering much akin to what we went through in March and April, and we wouldn't wish that on anybody, of having to put mortuary trucks, refrigerated trucks outside their hospitals because the death rates are so high. So when CDC sees the hospital rates, the ICU rates, the mortality rates increasing nationally, and they're giving national guidance, they're saying we need to prioritize the people who are most likely to end up in hospital, put pressure on hospitals, and to succumb to the illness in order to protect not just their lives, but our ability to treat people who are sick. And so that's really where the switch came from nationally. We're very lucky in New Jersey. We are seeing increased pressure on our hospitals, but we're not seeing the kind of pressure we saw in April, in part because we expanded our infrastructure and learned a lot from that experience. But writ large in the nation, it is happening across the country in a way that this guideline was meant to protect our healthcare infrastructure as well as people's lives. So if you go back to where 1B in the essential worker categories are, this is what you very often would see in the press, these lists. And one thing it's important to emphasize, besides the fact that these are the ACIP federal recommendations, is that they're also not in a priority order. And we do know, for example, that our educators saw themselves as second in line. So once they knew that 1B had been open to first responders, there was a reasonable assumption, well, we're next. And that was not necessarily true regardless of the switch, but especially when the federal government made the switch, it caused us to reevaluate how quickly we could deliver vaccines to anybody else in these categories. The state of New Jersey is still finalizing our decisions about how we evaluate essential workers. Frontline workers is the distinction they make, and other essential workers. And I'll just give one example, that there's a lot of thought that a lot of our public transit workers need to be in frontline essential. Our bus drivers, our paratransit drivers who drive people who are medically fragile and come in very close contact with them, helping them get on and off of vehicles. There's a lot of room in here for interpretation. And so our DOH, our Department of Health, along with our PAC, is making final evaluations. But the timetable for this, which for us originally had been the middle of January, has been thrown a loop because we have just, by nature of the CDC guidelines, been asked to open up vaccines to 65 and older, 16 and 65 with those risk categories, which is well over 1 million people. And if you go back to our vaccine supply, which is remaining stagnant at about 100,000 a week for first doses, we all can do the math and see the kind of trouble we're in. I heard someone just before we got on that their appointments in April. If we open up right now at the current level of vaccine supply chain to more categories, they may not see an appointment until June. That's frustrating. And it's may change if we know in the next month, the new administration will be able to up our supply of vaccines. So what we're more likely to do right now, and I don't have the authority to decide this on my own and they haven't made a decision, but what we're more likely to do right now is hold where we're at until we have a better assessment from the Biden administration about what a reliable increase in our supply chain of vaccines will look like, and then open up additional categories as they become available. This will also give us the opportunity to smooth out some of our kinks in the logistics process so that when more people come online, they're not going to be as frustrated as some of the people were when we, overnight, based on CDC recommendations, said 1 million more people can now access the system. So ramping up in capacity should, we hope, be aligned with our infrastructure goals. I think right now our infrastructure goals might be slightly ahead of our supply chain, which is a good place to be in one way, but depressing because what we really want are just more vaccines. We have hundreds of vaccine sites that are eligible and ready to accept if we had the supply to deliver. So important to know right now, there's 2 vaccines on the market, Moderna and Pfizer. Pfizer is primarily used in hospital settings and in the long-term care settings, in part because of it's more complex to store, to mix and deliver. The Moderna one is the one that you're more likely to see at our mega sites and some of the smaller medical sites. 2 doses are required of each, but there's different days apart. And that's important to realize, just in case you say to your neighbor, hey, I got vaccinated at the hospital, I got to go back in 21 days. And your neighbor says, well, I'm going back in 28 days. Why is that? Probably because you got a different vaccine manufacturer behind it. These are minimum number of days. If you go over the days, it's supposed to be okay. But our goal is to have everybody vaccinated within that, very close to 28 and 21 days respectively. And we're basing our second dose supply chain on people meeting that. So it's really important that when you get your first vaccination done, you get a card that you know how and when to show up for your second one, that you do not miss the second dose. Also important to note, for full transparency, that the governor signed an executive order a couple of, I would say maybe a month ago, I think it was December, that everybody would be automatically entered who's getting a vaccine into our NJIIS system. so that we can track your first dose and know that we can come back to you to make sure you're getting your second dose. You would now have to opt out of that system. Before, it used to be an opt-in system, but we need to be able to track people's first and second doses. So unless you affirmatively opt out of the system, when you get your first vaccine, you will be registered in the system so we can help track. The 6 vaccination sites, 4 of which are open of our mega sites. The Middlesex one and the Moorestown and Burlington are currently open, as well as Rowan and Rockaway. The other 2 should be coming online within the next week. Atlantic City, I want to say, is opening this week, and Rutherford maybe as well. I'm sorry, I don't stay on top of all the dates. They will be given a stable supply of all vaccine supply week to week, so they know what they can do. Some of them have their own registration sites, but most of them we're trying to link into ours. I'll get to that in a minute. And then there's over 250 sites that are ready to accept vaccines, about 120 of which are supplied with vaccines right now, including our hospitals, our FQHCs, federally qualified healthcare centers, ShopRite pharmacies. There's at least 35 or 40 that are delivering vaccines. Rite Aid, a chain pharmacy, also is delivering vaccines. Some urgent cares, there are county sites being set up, some universities, a few doctors' offices have access to it right now, and some local health departments. The way that they got to it was to qualify for a vaccine site. They put in a request for vaccine, and then they come back and they get a supply from us. It's not a great system right now. They have to come to the state, say, this is how many vaccines we want. We have to go to the federal government saying, this is how many vaccines we want. The federal government tells us how many vaccines we're actually going to get. And then we have to go back to them and say, based on your request and what we got, this is how many you're actually getting. There is discussion I've heard, I have no idea if this will happen, that the federal government may shift to a direct appropriation of vaccines to sites, which would take us out of the middle person. Pros and cons to each. I don't know which way it will land. But right now, we're all trying to juggle giving all of the sites that have the ability to do vaccines a stable supply so they can be predictable in their appointments, while at the same time trying to be fair and equitable in the process. This is just, I'm sorry, it's a little fuzzy, it looks like. Just to give you a sense of where our vaccine sites are and the way that we're tracking it, we're going down into social vulnerability index and zip codes to look for vaccine deserts, for places where we have low income or hard to reach or difficult to provide, to build trust with communities, to make sure that we're going to have locally accessible vaccines. Down the line, we're looking at mobile units or pop-up units. That would be much easier when we have a single dose vaccine versus a double dose. And we're also looking at aggressive campaigns to do information, which I'll get to in a sec. Basic, most easy resource to go to is the COVID NJ.gov vaccine page. If you go to our hub that I'm hoping all of you have used throughout the whole COVID pandemic, and you type in vaccines to the search box, you'll come to the home page. There'll be lots of information about safety, about access, about eligibility. Everything else is there. And then there is the registration site, which is linked on the main page for to get into the NJVSS system. The NJVSS system is being built as we use it, so it's going to have constant improvements. We appreciate when people register there, because you will get notifications of eligibility. The CDC new guidelines forced us to go back in and change what we were actually building in there, because we hadn't thought we were doing 1B and 1C right away. So those eligibility notices are still going out from the system. So if you did register, you are now eligible, and you haven't got the letter, you should know that they are being generated as we speak and should be going out. But it will help you know when you're eligible. And then we are trying to push all vaccine sites into our system so that you can either access the direct site to register through it or access an appointment through it. Different interfaces cause us to do different things. It won't be one kind of way fits all. But for example, Essex County has vaccine sites. And if you say you want to try to get an appointment, it simply reroutes you to their registration pages. So we're working all of that. We're trying to stand it up, but it is not the only way to register for a vaccine right now. You can go into the ShopRite pharmacy ones. Rowan has its own vaccine registration page for the mega site with its partner Virtua. So there is a page, if you go to our general information page, there is a page that lists every vaccine site we know of, and we should be able to list all of them, and how best to register for that site. So it's a little bit complicated. It's a little bit messy right now, but you have opportunity both to use the statewide system, which we appreciate if you register in, and the list of all the sites and shop around for where it might be easiest for you to get a vaccine. I know someone who tried to get a vaccine up in Bergen County. They were told they had to wait a month. They tried the Rowan site. They got an appointment the next day. Appointments open up. So if today you don't find an appointment in the near future or close by, you might want to try again tomorrow. Sometimes, depending on the way they allocate the use of their vaccines, sites may find that towards the end of the week, they have extra doses that weren't used. So they may open up more appointments towards the end of the week. So it's a little bit of a shopper's market. You got to look around, but chances are if you keep trying, you will find a place where you can get a vaccine. The other reason it helps us if you use the state system is the data will be automatically merged with like the NJISS, the back system, so that it helps us in recording the data in getting your vaccination records updated. So there's advantages for both the front end and the back end if you register here, even if you don't make your appointment. Important to note, no cost to vaccines to you, the person getting vaccinated. Insurance will be billed if you have insurance. So you will be asked for insurance information. If you don't have it, you can still get an appointment. We've seen a couple of vaccine registration sites where they don't let you get past it. They say insurance information required. We're working with those sites when we see them to correct. You also should not be asked to prove your status when you arrived at the vaccine site. If they let you register, you should be able to go in. We don't want anybody turned away because they didn't bring a work ID to prove where they work, or they're not proving they're a firefighter or a healthcare worker. If the system of the registration site lets you through, you should be able to get a vaccine there. Also know that some places are allowing walk-ins if they have an extra vaccine, or they keep a wait list of people who live nearby for the end of the day, so that if they have unused doses, they're never going to waste. So it's also worth looking into those. And there should never be a request for citizenship or residency asked of anybody. We will chase that down and correct that if we find out it's happening. There is a broad deep education program going on to answer questions about the efficacy and the safety of the vaccine and to raise awareness. We're trying to run this parallel to our access so that we don't build up expectations and then it's too hard for people to get appointments or they find out they're not eligible. But that material is rolling out. There's also a newsletter, Vax Matters. I think it's weekly, but don't hold me to that you can sign up and get up online, and the resources we'll share with you to register for that. And if it's going to come up, I did have a video. Yes, here, I'd just love to share with you a quick piece of the type of information we're pushing out together. And if somebody could give me a thumbs up, you can hear it when I start play, then I'll know I'm not wasting your time if you can't.
Absolutely.
I'm Dr. Sharif Elnahal, President and CEO of University Hospital in Newark. The COVID-19 pandemic has been devastating to the world, our state, and our communities. Many of us know people who have died from this disease. We've seen people survive but suffer from lingering effects. We've seen businesses close and many struggle with unemployment. That's why I'm grateful that vaccines are now available to help us end this crisis. And that's why I'm urging everyone in the medical community to get vaccinated. Some of you may have questions about safety. I understand, but here's what I will tell you. I was part of the Moderna trial. I signed up because I believe in our testing process. I know how stringent it is. I also know that the science behind these vaccines had been in development for over a decade. I knew that the entire world was working to solve this problem and that together we would get it right. The testing has shown that these vaccines are safe and effective. The FDA and international independent regulatory agencies have confirmed this. I'm asking you as a colleague and a member of the community that when the vaccine is available to you, you get vaccinated. It will protect your health and the health of our patients, families, friends, and communities. When COVID-19 hit, the medical community rose to the challenge. We will do so again. Let's get vaccinated and end this pandemic together.
So there will be a lot more of this coming out over the next few weeks, and we'll continue to try to use validating trusted voices from communities. This one was obviously geared towards people in the medical profession. And it may or may not surprise you to know that in some places where there have been surveys, upwards of 40% of people within the medical community are not sure they want to get vaccinated. Understand that we're also talking about custodians and food service, people who may not actually be in the medical profession per se, who really need to have the education and the time to ask questions before they're going to feel comfortable. So we're continuing to work on this material. We will share out when we have a toolkit that you will be able to use within your communities as well. It's always a challenge for me to get out of this. Here we go. The last thing I want to leave with is that as much as we're excited and focused on the vaccines, we have very high numbers of COVID positivity in our communities. These are post-holiday surges that we anticipated, with the added problem of probably the new, more highly contagious COVID being prevalent here. There's very little, I think it's called genome testing, the doctor will correct me, going on, to determine that, but you can assume based on what we're seeing that it could be here. So we're going to have to continue to wear our masks, to socially distance, to stay home if you're sick or having any symptoms, to avoid large gatherings, and do all the things that we have, emphasized over the past 9 months. And that includes even once you're vaccinated. We don't know for sure what levels of protections in terms of contagiousness could happen with a vaccinated person. There's a whole lot of stuff we don't know. These behaviors are our social norms for the foreseeable future. And we are concerned that people's focus on the vaccine is taking them away from accessing testing if they're not feeling well and from following these. So we will continue to have strong campaigns around this, and we would ask you to help participate in that. I know there are probably specific questions about educators and the education community, some of which are going to be best directed to our council and our doctor on the phone, but I'm happy, David, to try to take any questions from members here that I'm well enough prepared to answer, but would welcome interruptions from colleagues if there's questions that are better directed towards others on the call.
Thank you.
That gives you some overview. Thank you, David. Turn it back to you.
Absolutely. Thank you so much. It's incredible information that you're sharing. We will ask for those who have questions to type them into the chat box, and we'll work our way through as many of those as we possibly can. One of the questions that I do see already is, assuming you are confident at some point soon that the supply chain will increase, that you'll have more supply coming from the federal government, would you anticipate prioritizing groups 1A through C first and having those individuals have access sooner, or broadening initial access to other groups?
So our hope is that, absent any additional guidance from the federal government, that we would next be able to move into 1B of essential workforces, frontline essential workforces. That determination of exactly who New Jersey defines to be in that group is still under final consideration by the Department of Health. I certainly anticipate it to include educators. And when I say educators, I mean the broad education community of people who are in the school buildings and providing the support. So our transportation people, et cetera, within the community, just as we defined healthcare broadly. Whether we will follow every 1B recommendation as per ACIP or 1C, I can't speak to that, because, for example, these conversations, I'll give you a concrete example. Our motor vehicle employees are front facing, in contact with a huge number of general public, and we're having to close motor vehicle centers when there's a positive case, because they work, out of the nature of the way these offices are designed, in close contact. They have physical barriers, they have masks, but at the end of the day, we're not going to risk a full spread in an office. We're going to close an office for 14 days. That's why you see all these MVC closures. So we may say, for the essential service of motor vehicles, we're going to push our motor vehicles employees into 1B, even though that wasn't specified by the federal government. We have that room, and those are the final determinations. But in every conversation I've been in, educators are considered to be part of the next essential workforce of 1B, and we certainly hope to be able to move to that as soon as we have a better supply chain in store.
So one of the areas of anxiety that we're hearing from folks is that perhaps they'll be able to get their first shot, but are they really assured that the second shot will be available either 21 or 28 days later? Anything you can say on that question?
Well, I can tell you that I have been assured multiple times, because I raised that question fast, furious, and early, because when the previous administration, and I'm just, every time I get to say previous or new, I'm so happy. When the previous administration told us they were setting aside the second doses, I was skeptical, right? Because they also said we would receive over 400,000 doses and we received under. So why do I trust that? And then there were some stories recently about how the stockpiles were actually depleted, and that caused a lot of concern around second doses. The reason the stockpiles were depleted is that their manufacturing levels were increasing, so they didn't feel they had to hold those doses back, that they would have both the first and the second doses available. I remain more optimistic today than the day before yesterday that those second doses will be in place when we need them. And we're already well into second doses, right? We started December 15th with Pfizer, which is a 21-day, so it's a 3-week separation. Everybody is receiving their second doses as needed. And we are receiving those second doses on schedule in the quantities that we need. So at this point, I think our confidence will only increase that that will continue to happen. And also remember that those are minimum days. So if, for example, you're at 21 days and you got a Pfizer vaccine and you couldn't get the appointment right at 21 days, you can get it at 25 days. That's also okay. And people should know that. But so that's a minimum. We want you to get it as close to the minimum as possible because the safety of the, your immunological response is greater when you've had both. But a few days after isn't going to hurt, and even if it's stretched a little longer. But the supply chain should not be a reason for delay.
And certainly I know that hopefully folks are understanding this, that it is critical that you are not mixing and matching vaccines. If you have the Pfizer vaccine for the first shot, it must be the Pfizer vaccine for the second shot.
Yes, and we are trying to make sure people go back to the same site. That one of the ways to minimize the risk of that confusion, where you get your first shot is where you should be getting your second shot. And they should facilitate helping you get that appointment. This will become increasingly an issue as more and more people get round to the second shot. A lot of people who are eligible for second shots now are in long-term care or hospital settings, but you should plan, if you're driving from Teaneck to Rowan for your first shot, you got to be willing to make that commitment for the second shot too.
And of course, there is fear among some individuals about the potential side effects of these shots. And there are specific concerns if somebody is immunocompromised and in some other areas. Can you speak at all to how the state is addressing those issues and those fears?
So I will be very careful here before I defer to the doctor, so I'm not too far out over my skis, but I will say two critical pieces from the vantage point of a government official who's not a medical doctor. One is that we made very clear that we would not distribute a vaccine in the state of New Jersey that our medical experts in the Department of Health did not review the science of and make sure we felt comfortable with. Our commissioner was very clear on that because there was a lot of concern about the federal government rushing this. And so they did a full review and felt very comfortable putting these vaccines forward with respect to their safety and efficacy. The second thing is we have a lot of material out about vaccine side effects, and I don't feel medically qualified to say anything about it, but our campaign will include, what you should expect, which are normal side effects, what people should do who have complicated medical situations or any questions. But we are very confident or we would not be doing this. And as painful as it would have been not to do it, we would have gladly taken that heat if we didn't think these vaccines were ready to bring to market. But for the specifics, I'll defer to the doctor on the line.
And we will have Dr. Yankus speak about that in a little more detail in a follow-up presentation here. So one of the other questions that folks are thinking about, and I think I know the answer to this, but we really do not have a timeline, I assume at this point, when this could possibly be available for children. I assume you don't have any real idea of that. Is that right?
Nothing concrete. The trials of Pfizer and Moderna have started for children. I don't remember whether Johnson & Johnson was doing trials already for children or not. Dr. may know. Our doctors on staff are saying most optimistically it might be spring and probably not early spring, but it could easily be later spring or summer because the trials are only going on. I mean, I think the most optimistic would be spring, but work backwards from the fact that we don't know the result the trials will show, so it's hard to say.
Great. One final question I'll raise. We know that there is a potential issue with individual employers down the road, potentially looking at mandates from the state level. I believe there's really no effort underway at this point to talk about any sort of a mandate for vaccination. Is that correct?
Yeah, I mean, we know that's an issue. So to say there are no discussions would be disingenuous
Sure.
because we're having the discussion because we know it's a discussion.
Yes.
And, you know, attorneys weighing in and informing, and we're gathering that information. I think, you know, because of where we're at in the vaccine process and access, it would be premature for us to weigh in with any legal action or executive order action if we were inclined to do so. So I think right now we're kind of looking at the landscape and evaluating that. I think a few more months of data and information will significantly shape our ability to weigh in. There's also a piece which really belongs to the legislature on this for a long-term decision about vaccination requirements. So we have partners in this that we would be working with. You know, I think we recognize how important this vaccine is to resuming some new normal, but yeah, we're just not there yet.
Yeah, absolutely. So I do not at this point see other questions in the chat. I want to thank you again for an incredible presentation on very short notice, and I know how busy your schedule is. So from all of us at NJPSA and FEA, thank you so much for taking time to do this.
My pleasure, my honor. If I can answer other questions later or bring this or a like presentation to other organizations, please feel free to reach out. We feel like the most important thing we can do in the governor's office right now is be transparent about the work we're doing. I should say there is a dashboard live about our vaccination numbers, just like the testing and positivity numbers. The most important thing we can do is trying to answer your questions, being transparent and building confidence. So we're here to partner with you, and we're also here to get your feedback. So if you have feedback, good, bad, or ugly, we accept it all, and we will try to course correct where we see there are problems, and we can smooth everything out. So thank you all for your professional dedication to this and for your personal patience in this. And we look forward to talking to you more soon. Thank you.
Thank you so much.